This is one interesting case with so many things to learn from. This is the patient's pre-op picture showing an immature cataract, and this is the fundus which is not very clear, and this is the OCT which shows some ERM which has inverted the foveal tip, but however it was destined that this patient will be operated for the cataract, and then we'll see if we need some improvement for the retinal problem. However, as we can see, this is the other eye which has a posterior synechia and a 360-degree membrane formation at the pupil, and which allowed very poor vision in this eye. So essentially this patient was an only eyed patient for all practical reasons. So surgery was initiated, and as it's an immature cataract, I usually don't fully open the oblique illumination and just work with the retroillumination, providing me the glow, and I call this moonlight phaco or moonlight capsulorhexis, which provides less illumination, but it is good enough and comfortable patient for lack of very bright illumination, so patients cooperate well. Once we have hydrated, then we can switch to full illumination, because now the cataract is denser and the illumination will not bother the patient as much as it would through a clear lens. So we will just proceed, and it's a routine cataract surgery, and it's a mature cataract. Hydrodissection has been done, and so it's a time to chop this. So we bury the tip and perform a primary horizontal chop, having a full thickness chop in one go. The nucleus is subsequently rotated and further chops are made, so as the nucleus is disassembled into smaller pieces. It's a mature cataract, a soft one, so it's not very difficult, but at the same time the immature and soft cataracts may be a problem because they tend to be strong enough for the chopping process to happen without any problem, and once you hold them, they simply the bites off the holding piece and you don't have anything to hold on to. However, the nucleus has been removed, and what is left behind is an epinucleus. And although this can be safely removed using visco, using the phaco pro, but I decided otherwise, and I switched to irrigation aspiration cannula. The point here to see is that the epinucleus is usually bulky, so the irrigation aspiration cannula, which has a smaller aspiration port, will take significantly larger time, but at the same time it becomes little safe. You will also see the epinucleus is something like a cup which is molded onto the capsular space, so it's difficult to remove when compared to cortex, and one has to literally engage the epinucleus, deform it, and then pull out of the bag. So it's in contrast to cortex, which is not so molded and doesn't have so much of integrity. So one has to actually reach up to the posterior capsule to sweep it across away from the posterior capsule, and at the same time keep on aspirating at a low vacuum and low flow rate so as not to damage the posterior capsule. It will take some time, but I think this is safer than removing it using a phaco tip. So massaging the epinucleus and engaging it using good control over the foot switch so as to manipulate the vacuum and flow rate as is required. So we can see at this moment the subincisional cortex is being removed, and this is a small piece of cortex which is subsequently aspirated out. So once the nucleus and the cataract is removed, when it's the time to implant the intraocular lens, a small wisp of cortex which is being left behind will be aspirated with the safety of the IOL. It's a hydrophobic monofocal head-off lens, and we will see it's a preloaded lens, and this is what happens. The moment the lens was inserted fully, I realized the trailing haptic has been cut off. Now this is a problem. It can happen with any one of us, and then the problem is that you have a IOL which is not having complete haptic, and that is why it will remain decentered. So it is not wise to leave these kind of IOL in the bag, because they will be loose, they will not get centered, so it will be optimally not providing good refraction, it may cause diplopia, and at the same time this IOL may dislodge into the anterior chamber touch the cornea and subsequent problems. So the incision was enlarged slightly, not to the extent that whole of the haptic is accommodated, but rather the plan was to fold the IOL in the bag, and the twist and pull technique, as had been described by various authors, will be used here. So using a lens holding forceps, one grabs the optic, and using the dialer one puts it and then twists the optic part so that against the force provided by the support provided by the haptic, it can be twisted and pulled out through a smaller incision intact without cutting the IOL optic. So that broken haptic IOL is being removed, and now it is time to insert a fresh new intact IOL. So this is also emphasizes the importance of having backup IOLs in your OT. So this time the trailing haptic is fine, and this is also a preloaded IOL, and the optic and the haptic goes into the bag with nothing going wrong as the outcome of the surgery is unfolded. Now it's time to remove the viscoelastic by doing irrigation aspiration, and the surgery is hydrating the wound so as to seal the anterior chamber. This is the day 1 picture, which shows a clear cornea, a centered IOL, and a good visual gain. Thank you.